All right, here we go. Hi, everyone. Welcome to our webinar, 10 Attributes of a Health Literate Organization with Tom Bauer and Michelle Heacox of Johns Hopkins. I'm posting some housekeeping notes here on the side here. My name is Jill Patton. I am the content manager for IHA. I'm filling in today for Julie McKinney. And I'd like to welcome our speakers. Tom Bauer is the Senior Director of Patient Education and Engagement at Johns Hopkins Medicine. And Michelle Heacox is a Patient Education Specialist of the Patient Education and Engagement at Johns Hopkins. I think I just bungled that a little bit, Michelle. But
okay.
I'll go ahead and turn this over. I did want to note that this session will be recorded, and the recording and slides will soon be available on the Health Literacy Solution Center webinar page. And I'll post that here in the chat as well, in the comment section. Please use the chat feature for general comments and discussion related to the webinar, and the Q&A feature to submit questions to the speaker. And hold on a second here, I'll post this here. And with any technical issues, you can also reach out to us at this email address. And if you ask for continuing ed credits, please fill out the survey at the end of this webinar. And then I think we're ready to go. Michelle and Tom, I'll go ahead and turn it over to you.
Good afternoon, everybody, and thank you to the organization for providing this opportunity for Michelle and I to share our journey at Johns Hopkins Medicine and becoming a health literate organization. And I use the word journey in this conversation because you really never get there. It's like perfection. You don't get there, but you just get closer. And so I use the word journey very directly and intentionally. Slide, please. This is an accredited education activity. Go ahead, please. These are our learning objectives for today. Go ahead, please. And so let's start with this. And most of the folks in this audience already know this, but health literacy is a silent epidemic. It affects 9 out of 10 patients that do not receive health information in a way they can use or understand. And I will share with you the first time that I heard this statistic, I thought it was overstated. And then I did my first presentation to a large group of nurses, and there were about 500 nurses in the room. And I said, I think that's a little overstated. And the overwhelming response was this: it's understated. And I was really surprised to hear that from the audience. And I said, well, why do you believe that? And what I heard from my colleagues was the fact that they felt it was higher because it was also the number of phone calls they got from family, friends, and acquaintances sharing their health journey with them and their misunderstanding of it. And so it wasn't just the patients that they saw, it was mom, dad, sister, brother, neighbor, and so forth. And so they really saw 9 out of 10 as the real number. And so I thought that was fascinating and validated the research done by the Department of Health and Human Services. Slide. So why is health information so hard to understand? And there's a lot of different things that goes on here. The first thing that I think a little bit about is in that same presentation I mentioned earlier, it was at 8 o'clock in the morning. And one of the things that I do when I do presentations, particularly early in the morning, is I listen to music to kind of get myself going a bit. And on that day's journey, I was listening to Bruce Springsteen. And there's a song that he sings called I'm on Fire. And there's a line there that says, sounded like a freight train running through the middle of my head. And so while I was presenting, I said, when someone hears the words they have cancer, it must sound like that lyric from the Bruce Springsteen song. And as I said that, one of the nurses in the front row stood up and said, Tom, that is exactly how it sounds when you hear that. I am a breast cancer survivor and a healthcare professional, and that's what it sounded when I heard those words. And so when you hear those words and you hear that freight train running through the middle of your head, how can you hear anything else? And so you've got anxiety, you've got the fact that the work that we do is highly scientific, it's advancing all the time. So we have a lot of medical words we use, a lot of medical jargon, it's high science. And so there's a multitude of reasons. But the bottom line is that 9 out of 10 Americans today do not receive health information in the way they can use or understand. Slide. So what's the impact? And so when I think about it, how can I get healthy or stay healthy or achieve my maximum health if I don't understand what I need to do? And that's really the impact. Slide. So what are our guiding principles? Slide.
I'll
Michelle?
take it. Yep. So one of our guiding principles has been to rely heavily on our best practice. And part of our journey has included trying to find the best method or tool for patients that best meet their needs for learning, whether that be written, visual, oral and auditory, and tactile interactive, and all with the end goal being patient-centered health education. Slide. So we did, I guess it was several years ago, early on in our journey, we did 2 patient education surveys, and we surveyed we surveyed our healthcare professionals, and we surveyed over 1,000 individuals over a 2-year period. And we saw a theme emerge, and that was to make Johns Hopkins medicine easy, both easy for the patients and easy for the providers. Slide. So we began to build the foundation. Slide. And I'll refer to these 4 blocks as our foundation building blocks. And the very first part of this was to have support from the top in the organization. And the realization was that we needed a leader who would be a champion for patient education. And that's when Tom was hired as a senior leader. And the other point I'd like to mention that's very significant is that patient education became and was part of the strategic plan. So then for the second block here, we realized that we needed to have consistency across all the hospitals within our organization. So it involved key strategies for selecting our vendors so that they could be shared across. And then we had to look at the third block, which was how are we going to make this easy for all involved in the education? So this whole process was where we began to embed patient education into the clinical workflow and the patient's portals. And then we realized that we had to educate the team so that we could do all this. And you can see here what's listed are the ways we began our education. And we'll talk more about that later. Slide. So we realized that there were opportunities in the foundation. At the time when we began, not all of our material was translated as it now is. We have 100% of our material translated into Spanish, and we have our top 5 other languages. And we also saw that there were some gaps and pockets with some of our services for physical rehab, mental health, nutrition services, emergency medicine, and pharmacy. And early on, one of the kind of workarounds this was for Johns Hopkins Medicine to create our custom content for patient education, which we then added to the patient education library. Slide, please. This is one of my favorite slides. I always say this, Tom smiling, and that's because Tom created this, but it's so meaningful and shows how we built the foundation layer by layer, process by process, tool by tool, and with our goal being to have that patient education and engagement easy for all of us. Slide. So once we built the foundation, of course, we realized we needed to maintain the foundation. So we created an access database that helps us monitor all of our material, written and video, and we have a process for reviewing whether it's a triennial review or a annual review. All materials reviewed for health literacy best practices, and we do have subject matters throughout the organization. And of course, we have dedicated team members, and I'm one of them that maintains the foundation. Slide, please. Tom, I'll turn it back to you.
Right. So what's next? First, I want to apologize if you hear us saying slide. We ran into some technical difficulties as we prepared for the presentation today, and they happened just as we were beginning. So we're just saying slide to let them know to move the slides for us. And so what's next? Slide, please. So we expanded our resources to create patient-centric patient education. And so when you look at the typical is written, visual, oral, auditory, and tactile interactive. And so when we look at the traditional written, we felt that we had a very strong library there. There were holes that needed to be filled, and those are areas Michelle talked about as we built the foundation. We also needed to integrate that education into the continuum of care. And so we spent a lot of time there. We also then, which you also see is the white. Whenever you see something written in white, those are things that are new that we added. For the first time, we had our system-wide vendor selection process to select the providers for our written and our video. And now we have 3D animation and e-gaming. We'll talk more about that a little bit later. And then in the oral side of the world, we have always been strong in teaching teach-back. And then what we know as a profession is that we always tell a person what's wrong and what they need to do, but we always don't include the why. And so we wanted to focus on it. And we also learned that people prefer podcasts sometimes, the auditory learners, and ebooks that are also visual, but they can read to you. So we started expanding our resources. On the tactile side, we've always had like the models that you see in the physician's offices and so forth. But now we're looking at e-gaming and animations and avatars. So really starting to build out our library, our tools, so they meet the preferred learning styles of the patients that we have the privilege of caring for. Next slide. So let's get into the 10 attributes and how we start to meet all of those various opportunities. Slide. So attribute number 1 has leadership that makes health literacy integral to its mission, structure, and operations. Slide. And so one of the things that I did when I first came to Johns Hopkins is I pulled a strategic plan and I looked at all the strategic initiatives within it. And what I noticed was that inside of all of these key elements, there was a health literacy component to it. And as all of us know who work in health literacy or patient education, we know the wide impact of the work we do. And so it was very clear that they impacted each of these elements. And so I had an opportunity to sit and meet with the architect of the Johns Hopkins Medicine Strategic Plan and shared with them how health literacy did impact each of the elements. That opened the door for me to become a member of the Strategic Planning Committee and to have specific action plans built into the strategic plan that were health literacy related. Slide. We also then needed to develop a structure. And so what you see at the bottom, the very bottom row, is those are our patient education committees for each of our hospitals, ambulatory, home care group, and so forth. And each institution has its own committee, its own chairs. And the chairs of those committees then sit at the Johns Hopkins Health System Patient Ed Committee. That committee is chaired by myself, and then that provides the oversight for patient education across the system. And what happens is there's a flow of information that goes back and forth. So let's say we find an opportunity at one of the hospitals, it comes to the system committee, and perhaps another hospital or entity has solved that. We share it, we bring it back. Sometimes we see it as an opportunity across the system, and we work to resolve that across the system. Sometimes we identify best practices in the health system committee, and we move that through the implementation through the various committees. So it's a back and forth, but we don't operate in isolation. And so what you see surrounding the circle in the middle is the group of departments or programs that we interact with. And some of our key strategic partners is obviously the strategic plan, which has been instrumental to our success, working with marketing and communication to share our resources and projects we're working on for Harmony. We work with our EPIC team for the EMR side of the world. We work with our Safety Institute. We work with our diversity and health equity teams as well. And there's more. That list is actually larger than what you see on this slide. But the key is integrating this work into the fabric of the organization. Slide. When we created these various committees, we sat down as a group and we created charters so that everybody was aware of what the role of the committee was, what their areas of responsibility were, how information flew back and forth. And that really helped to get everybody on the same page. And we created it within each of those committees and had them all approve it. That way, everybody had an opportunity to truly participate in its creation and help understand. And that's been a key to our success. Slide. Attribute number 2, integrates health literacy into planning, evaluation measures, patient safety, and quality improvement. Slide. And so these are just a few examples of things that we've worked on when you look at strategic initiatives within the organization. We've had a very large effort surrounding sepsis. And in that process, we are a part of the sepsis community that is addressing sepsis. And so as part of that, we've created teaching plans to support what is taught to our patients. We have acquired or created written and video materials to support our clinicians and our patients. We've embedded all that information into the EMR to make it easy for people to access. We've also tied them into our bedside tablets. And then we had a corresponding social media campaign. And so a very integrated effort in which we are right in the middle of. And then a number of years ago, there was a change in some of the requirements for oxygen safety, and a committee was formed to address those opportunities. We were central to that committee, one of the work groups. And much like we did in sepsis, we did that with oxygen safety. And then, I don't know, it's been probably 5 or 6 years now, when the opioid crisis emerged. There was a large effort that was there. And once again, senior leadership, as they created these committees, created a patient education function to that. And so we were involved from the onset of that committee. Like the others, created the teaching plans and education to support our patients and our clinicians in addressing this opportunity. Slide, please. Michelle?
Okay. Attribute number 3, prepares the workforce to be health literate and monitors progress. Slide. So you'll see here some of the examples of the way that we do this. We do this through orientation. We have webinars and, of course, continuing education events. One of the things that became very evident during the pandemic was that we had to find a way to do all of this virtually. And we actually have kept most of this through virtual learning. Slide. So how do we monitor this? Well, we use something called the quadruple aim, which comes from the IHI, which is the Institute for Healthcare Improvement. And we look at this when we look at these measures, when we're looking to add a new project or monitor how something we've implemented is working. And we look at the cost, the quality, and both healthcare and healthcare professionals and patient satisfaction. And we have learned that health literacy really greatly impacts the quadruple aim. Slide. Attribute number 4 includes populations served in the design, implementation, and evaluation of health information and services. Slide. So we created patient family advisory committees. I'm sure many of you have these as well. And this group is just very important in helping us oversee the strategic planning for patient education and engagement. They help us form strategies. They help us look at what we're doing now, what we could be doing differently. I lost you for a second. Am I there?
You're here. We can hear you.
So I thought my internet went out. Sorry. And we have subgroups for our PFAC committees that actually are part of some of the clinical communities. Tom mentioned the pain and opioid clinical community and the work that has been done there in the past. But we feel they're very, very important members in helping us with our patient journey. Slide. So we have learned some lessons along the way, and some of these have become more evident even more recently. As Tom said, we're on a journey. But we've learned that there are differences and opposing preferences in what the patients, the families, in other words, the learner, wants and needs. Some people just prefer very short, written, concise information. Everyone's very busy. They want to know what they need to know, and they want to know it now. Others prefer to do intensive research, and they may want to look at clinical trials and want to watch every animated video they can so that they can just learn as much as possible. But one thing that we've seen is that what is changing is that people are looking for more education that is actually visual and multidimensional. And most people want to and have access to digital learning because most people have cell phones that can act as their computers. So we are, we're definitely seeing that the learning preferences have shifted. And I'm going to turn it over to Tom, who's going to address the gap. Slide.
Okay, so addressing the gap slide. And so what we started to do, and this really came about is during the pandemic. And what I realized is that the way we educate patients has not changed in my entire 40-year journey in healthcare. And so if I go back into the 1980s, the way we educate patients was written, oral, and video. Now, how we deliver the video was different, but it's still the same. We've done a lot of work as a community to improve, create health literacy best practices, so to improve the documents so that they're more understandable, plain language, things of that nature this group knows about. But I also realized that the way people learn today is different than when I, for example, went to school. And so what we needed to do was to take a look at how people learned and create, or how they prefer to learn, and to make sure that we had those tools or those resources in our toolbox so that we could meet their needs. And so when we first started looking at that, what we found is that 53% of all individuals prefer visual interactive learning. So they like to see it. And so the first step was looking at improving our imagery. And so we acquired a very large library of about 32,000 images. And as you can see, the nice advantage to the images is you can see the anatomy, you can see the structure, you can see what's normal, what's abnormal. And so it really allowed the patient to be able to understand. Next slide. And then to move that up and make it even a little bit better, we then acquired 3D animations. And so now you could see a heart pumping normally, a heart in AFib. You could then see, particularly in the heart with AFib, you can see the forming of clots, and then making it much more understandable to the patient what's happening to their heart, how it compares to normal, and why they need to take an anticoagulant. And so really taking that visual side and building it up. Next slide. And now you start thinking about something like virtual reality. The ability to take the heart and create it so that it's in the middle of a room. So if you're teaching a class and you had this large heart, the virtual heart, virtual reality, and have that available, you use that for teaching. We don't do that yet, but that's something that's very much on the horizon and not very far away. Next slide. Digital journeys. So when I begin to think about our patients who are underneath enhanced recovery after surgery, so that's called ERAS. In other words, our surgical patients. I'm going to have Michelle talk about that a little bit.
Yes. So we have the enhanced recovery after surgery that has historically been a very thick patient education binder that is given to patients. And what we've been piloting, really, we began in January with this pilot. We have deployed patient education at a point in time during their surgical pathway where it is more meaningful and valuable to them, whether that's pre-op, while they're in the hospital, and when they get home at discharge. And we provide, so they get information and they get videos throughout their journey. And so far, the feedback is very positive with the digital journey. Slide. Tom?
And then the next part of this that became avatars. And so when you start looking at avatars, the ability to augment our educators, our clinicians, so that our patients had the ability to interact with the avatar, which was teaching it, and ask questions. And it works in a closed AI system so that we're not worried that it's going out and getting information from poor sources, as it were. And so the avatars are going to launch for us the launch meeting will be in August. And so we're really excited to bring avatars because it has the ability to teach when the patient wants to learn. It is visual, it is interactive because you can ask it questions, and it grows organically based on the interaction with the patient and as the science evolves. So we're very excited about the avatars. Next slide.
So we have health portals for patients to be able to click on their, and we do this through MyChart Bedside and their tablets, patient tablets we deployed, and they can access it on their own devices upon discharge. But there is an education tab that they click on, and they can see the prescribed patient education. And it's working very well. We got off to a slow start in our journey with adopting these for the patients, but it's going very well. Slide.
And then the metaverse. This is the one that's further out in the distance. But imagine the ability to recreate a medical institution in the metaverse and allowing a patient to interact with it before their visit so they can experience what it is to park in the parking garage and find the elevator and get across to the hospital itself and be welcomed and walk the hallways as you're going to a procedure and to be able to talk to your nurses and your physicians and your other healthcare professionals. This is something extremely exciting. It's down the road, but we're actively working in this arena. So when the time comes that it becomes more affordable, we'll be ready to do that. Next slide. Michelle?
So for podcasts, we did a little bit of this a couple years ago, and we have exciting plans for the, I guess, late this year, maybe possibly early next year, to embed podcasts into the EMR. And we have an example. A good example is we have, again, another booklet that's for maternal child health. And we have recently digitalized that so that that can be deployed digitally. And then the plans are to then take what is in that booklet and create that content into podcasts. And this will address the auditory needs for patients. And it's this particular patient population, we're thinking it will be good, like when they're in their cars or resting at home, but the podcast will probably be about 20 minutes or so in length. So we're very excited about that. Slide.
So attribute number 5, meets the needs of populations with a range of health literacy skills while avoiding stigmatization. Next slide. So we really looked at it as person-centered tools that we needed to develop. And so we talked about the 3D illustrations, animations, avatars, e-gaming, podcast. And so reaching the patient where they're at and how they prefer to learn. We spent a lot of time expanding our written materials and our video materials to ensure that translations in the most common languages are available. And then we looked at things that were more innovative in the sense of stoplight reports for chronic conditions so that a patient with heart failure, when they wake up in the morning, can look at the stoplight. And if they feel a certain way, they know they're in the green position and all is good. If they wake up and they see that they're in the yellow, they're feeling their conditions are such that it's yellow, they know to reach out to their provider, and if red, to reach out to the hospital. And so it really allows that different way of reaching our patients. And then we created a lot of patient-facing checklists. So really creating a diversity of tools to meet our patients where they're at. Next slide. Michelle?
Attribute number 6, uses health literacy strategies in interpersonal communications and confirms understanding at all points of contact. Slide, please. And Tom referenced this or alluded to this earlier in an earlier slide. Studies have shown that 76% of the time, we tell a patient what they need to know, what medications they need to take, what their treatment is, but only 24% of the time do we actually explain the why. And this is very critical. And we have done this throughout our education, but when I referred back to those triennial reviews and annual reviews, we're now taking a deeper dive and deeper look at our written material and our video as well. But we're looking to we're actually adding the simply plain question of why do I need to do this? Slide, please. And then I think all of us in the webinar know that this is the gold standard, and that is teach back is truly the only way to know if a patient really understands us. Slide. So how do you do this for very complex conversations? we use a principle called chunk and check. And one of the most complex topics or learning needs diseases is I'll use the example of diabetes, and how there is so much to teach a person who has just been diagnosed with diabetes. So you want to break that into small pieces and teach one part of it at a time, validate that transfer of knowledge through teach back, and then repeat the process as needed. And then once we're all clear that the patient understands and is ready, then your next teaching session, you go on to that next small topic of piece of the diabetes. Slide. Tom?
Attribute number 7, provide easy access to health information and services and navigation assistance. Slide. So one of the things that we started to take a look at was the fact that accessing our patient education was not easy. And that was true for our patients, that was true for our clinicians. And so we created a group to really take a look at the workflow, the clinical workflow, and the patient journey, and make corrections to resolve that opportunity. Once we did that, we saw a 213% increase in the use of our written materials, slide, and 193% increase in the use of our videos, slide.
I'll take it. Attribute number 8, designs and distributes print, audiovisual, and social media content that is easy to understand and act on. Slide. So the best way to do this is through consistent use of our health literacy tools. And we started using these tools very early on. And I think we are, we use PMAT, and we have on the right, you'll see an example of one of the health literacy calculators that we use and make it easy for our staff to access, where they can test their custom education that they may be creating. And this is kind of one of those, it's like up and down. As we get new staff, we kind of have to re-educate and work with them on making sure that our education is meets health literacy best practice. And the ultimate, or the end, what am I trying to say? The end result is that Tom and I are both the last step in the clearinghouse to ensure that we are meeting health literacy best practices for all of our education. Slide.
Attribute number 9, addresses health literacy in high-risk situations, including care transitions, and communicates about medicines. Slide. And so earlier we talked about the digitalization of ERAS, and that's really one of the things that when we talk about these transitions of care, so what you really mean by that is going from one, let's say the hospital to ambulatory, or let's say the ED to the hospital to ambulatory to the hospital. Those transitions can be very, very difficult. And that's a place in which many patients are at risk for potential harm. And so Johns Hopkins has been a leader in the enhanced recovery after surgery programs. It's an AHRQ best practice that we use, and it was developed at Johns Hopkins. And it helps our patients understand the journey that they're about to take. It allows them some questions and answers they may want to consider asking. It has checklists within it, so they can make sure these things happen along the way as they prepare. And it helps to reduce those risks along that journey and in those handoffs of care. Next slide. Discharge summary redesign, a safety initiative. And so what we're really talking about there is the after visit summary, discharge paperwork, whatever you may want to call it. That's an area of opportunity for every hospital in every city that I know of every organization. Because you're taking very complex, if you take a hospital admission, you're taking a very complex series of events that occurred. You're trying to summarize that into one document and then share with that individual what they need to do to care for themselves following the discharge. And what we found is that that is very complex. It creates a very bulky document at times, and it's sometimes not easy for patients to understand. And so we created a redesign effort in which we looked at the design to make sure that the flow of information was logical, and what we included was health literate and was easy to follow. And we created a criteria that said to be included in the after visit summary, it has to affect the care of that individual in the first few days after they're discharged. And so that allowed us some criteria of the multiple requests to add something to the discharge paperwork that didn't do that. And so really creating a more manageable document that's not intimidating. Next slide. Attribute number 10. Communicates clearly what health plans cover, what individuals have to pay for their services. Next slide. And so one of the things that we wound up doing is we spent a lot of time, Michelle and I, taking a look at a dedicated web page that helps people understand in clear language how to understand their bill. And as you know, billing has its own set of terms and jargon as their insurance companies. And so when you think about deductibles, co-pays, those types of things, explaining what they are and helping make sure they're understandable, taking a look at the bills that go out to making sure that those are understandable. Because the last thing we want to do is have somebody misunderstand what their coverage covers or what their responsibilities may be and not get the care that they deserve. And so we want to make sure that those were very clearly understood and in clear language. And so that went all the way from all the written communication, all the communication in the patient portal, and then all that we see on the web. Next slide. One of the things I wanted to take a moment is to thank my team. And so you see Michelle and I here on the webinar today. The person on the left is Penny Pearson. The person to the right is Tracy Bagwell. I am certainly a very fortunate individual to have the strength of this team that surrounds us and is the core of what we do at Johns Hopkins. And then as you saw in the slides on the organization, we're supported by a system patient education team, and then we have patient education teams that are a part of each of our organizations, be it home care or the hospitals or ambulatory, and then other departments that we interact with. So this is a team effort at Johns Hopkins because there is no way that we could do this by ourselves. And so my profound thanks to all those individuals. And what I'd like to share before we get to the wrap-up section of this is the 10 attributes has been an extremely important North Star for us as we developed our programs. When I first came to Johns Hopkins, I used that as my North Star to evaluate where we're at today and what our opportunities look like. And then along the way, we started to address all of those opportunities. I will share with you, we will continue to address those opportunities for all the foreseeable future. Because we said earlier, it's a journey. You never quite get there. And so for those of you who are working on some of these things, it's easy to get frustrated because there are days in which you come in and you look and you go, oh, I thought we were further than we were. That's going to happen. It's a part of the journey. And just know that every day you take a step forward, sometimes a step backwards, but it's moving forward. And so I encourage you, one of the things that Michelle and I talked about as we prepared for today, is to do something like we just did for the webinar. Evaluate yourself to the 10 attributes, and then in time, go back and revisit it. And what you're going to find is how far you've come without realizing how far you came, because it's sequential and slow. But when you go look at it year after year, it's amazing to see the differences. So thank you for all of those of you who attended, and we're more than happy to share more of our journey. Next slide. And that's really, this quote always struck me. Success is a journey, not a destination. The doing is often more important than the outcome. We know that we have a large number of questions, which we welcome. And so at this point, we'll go to that part of the conversation and bring Jill back into the webinar.
Yes, thank you, Tom and Michelle, for sharing your journey to find new and innovative and better ways to ensure that patients understand and can act on the information and the education you provide. So we do have time for Q&A. And I've got a few questions that have come in as you've talked. So I'll go ahead and start with the first one. And people can please put your questions in the Q&A, not the chat, and we'll see if we can get everybody through here. So here's the first one. Does it show up? How do you determine if the patient understood the content? And this one came in a little earlier. I know you talked about in Principle 6, teach back, but I wonder also about, asynchronously consumed tools. How do you know if people understood?
There's a couple different ways. And so teach back obviously is the gold standard. So an oral conversation and a follow-up to a video, those types of things, teach back becomes a very important component of it. Then there's also a learning needs assessment or learning assessment that's done. And at the end of the assessment, so when we teach something, we document that we taught it. And then there's the opportunity then to evaluate if the patient understood. And so we built it into the process to use teachback or methods to find how the patient learned. So we do that. That's more manual. And then when you look at the digital journeys, there's opportunities to say, I understand, I don't understand, I want more information. And so we're constantly seeking those opportunities.
Cool. Here's another.
Would you add anything?
What's that?
Oh,
Michelle, would you add anything?
No, I think you covered that well, Tom. I just, there's the old standard of return demonstration. That would probably be the only other thing to add there. And that's all part of your teach back.
Okay. And here's the next question. Sorry about the ticker version. I'm finding new ways to use this tool. So the next question is, are you producing different versions of content for different levels of literacy? I know you talked a lot about person-centered tools, the diversity of tools, but are you doing any leveling as well?
Well,
go ahead, Michelle. Do you want to cover that?
I'll tell you how I'll answer. We have a standard where we gear all of our patient education to between a 5th and 8th grade level, really with the goal, the ideal goal being 6th grade. We have had some pushback from providers, not patients, wanting some of the material to be at a higher level, but it's not a health literacy best practice to have it at a 13th grade level. So we're very consistent with that. And Tom, you may have more to add.
Sure. One of the things I would share with you as an example is when we were working on the opioid crisis, one of the things that we wanted to do is create information that was understandable to our patient and reached in different ways. So we wrote this one called Pain Management Safe and Right for You. And what we did is we have a short version and a long version. So the short version is it's a one-pager. It gives you basically the key points that you need to understand about your options in pain management. The longer version goes into much more detail. And so it gives you that opportunity for those who are more inquisitive, want a deeper dive. We have that. I am a fan of creating material that has multiple levels to it. So if you just want the facts, we've got that. If you want to dig deeper, we have that as well for you.
Okay. Here is the next question coming through. Regarding teach back, let's see, do you have any initiatives for patients that teach them about the practice so they can be more empowered without having to rely on the clinician to always initiate?
The answer to that is we do not at this moment, but it is on my plate.
Okay.
I am
what does that look like in your mind?
Yep, it is. I am a huge fan of patient use of teach back. And so when I go to receive my health care, when I hear the information, I'll come back and say, so what you're telling me is, and then I'll share with it, and is that correct? And that has worked marvelously for me as a patient. It's something we want to also initiate at Johns Hopkins. It just hasn't happened yet, but it's in the plan.
Okay. Let's see. Any quantification of cost savings since you've been implementing these practices, and where does patient education fall within your organizational structure?
So on that one, the answer to that is that it's really funny. I just started working on this. We created the Johns Hopkins Patient Education, Innovation, and Research Committee. And that came with meeting with our leaders of our provider leaders. And what we wanted to do is take the innovation we shared with the group, and we wanted to take top clinical leaders to help prioritize what we worked on and where we implemented these different initiatives to learn from. The second phase of that is then doing the research in an IRB type manner so that it's of the highest quality to really quantify the impact. And so that is going to launch in September, and we'll be taking a look at that because that's where all of our new innovations are coming. And we're going to then measure the impact. And then we'll be able to share that with our community, all of you, and within our organization so they can see the impact that this work has on patient care, looking at satisfaction, cost, quality outcomes, safety events, things of that nature. Where it comes to where do we fall into the organization? That's always an interesting question. I've worked in 2 organizations in this role, and it's been an active conversation in both. For Michelle and I, we report to the Department of Nursing at the system level because our director, our chief nursing officer, is responsible for the patient-centered care pillar of our strategic plan. So within that pillar, that's where we fit in the organization.
Okay. How do providers and clinicians react to your projects?
Michelle?
Extremely positively, for the most part. It's funny, we have throughout this journey and just along the way, we are reaching more and more multidisciplinary. Well, that's always been our goal, but we have more and more providers requesting that Tom Bauer and his team review this for patient education. And I think a lot of that has to do with the work that we've done in our track record. And I don't know, Tom, what would you add?
I would also share, I just met with one of our hospital's patient education committees, and all the work that we're doing to move into the future with all these other tools has been so extremely well received. I actually got applause on several occasions as I presented them, thumbs up that we're in the room, all that type of thing. Because what's happening is people understand that this is an opportunity. Healthcare is complex. And we're offering new tools, new solutions that will help them be better clinicians in terms of getting better outcomes and so forth, help our patients get better outcomes. Really, the key to all this at the end of the day is that we need to be able to share the positive impact of this work and also the depth of the opportunity. And so when people, I'll give you an example. When Michelle and I write for health literacy and do revisions, unless it's somebody we've wrote for a lot, what we'll do is we'll put at the end of when we send back our comments, we'll put a little graph on the bottom that shows the grade level before, after, the reading ease before, after. And we bring all that into that document so that they can see the improvement and understand that this is a science. It's also an art, but it's a science. And they can see the value of what we've done. And so the key is really providing that value statement, and that then drives the excitement that comes with it. Granted, there's tons of things that go on in healthcare, lots of things to get excited about, but that's what we do.
Cool. I have a couple of questions coming in terms of people, the patient's response. How do aging patients who often are at times not used to technology, AI and digital education react and respond to your digital projects?
That's an interesting question. So I'm going to flip that for just a second. And so what has happened is so long, what we said is, my patients don't have smartphones. My patients don't are digitally literate. My patients, and you kind of go down that road. And so you don't develop it. But then those patients who are digitally literate, who prefer to learn that way, who prefer to be interactive, don't have tools to meet their needs. And so as a result, we've taken a different look at this. And what we say is that not every tool is for every patient, but we must have a tool for every patient.
Mm.
And so when you look at the maternity side of it, for example, we have the book, we have the ebook, we have the videos, and we have the podcast. And so
Yeah.
if you prefer the book, great, we've got it for you. You prefer the videos, great, we got it for you. If you prefer to the podcast and the ebook, great. In the future, we'll have that for you. And so it's really about having enough tools to meet people where they're at, realizing that not every tool is for everyone, but that same topic needs to be covered in multiple ways.
Multiple ways. Okay. Hold on. The next question is, do you have materials and strategies for patients with intellectual and developmental disabilities in addition to health literacy challenges?
I'll have to take a moment to think about that one. I mean, we build everything in such a way that fits the best practices of health literacy.
Right.
That's a very broad statement, and so I'd have to think a little bit about that. So I honestly can't answer that effectively today.
Okay.
And I guess, you know, one thing would be to the significance of including a care partner, a family member, when we're faced with situations like this. But that,
But I
that's
also say, yeah, but that also goes back to developing the tools that reach the person in the way they prefer to learn. So
right.
there may be a person who has reading disabilities. So we have the audio.
Mm,
Um,
right.
if you can't read, if, for example, if you have visual issues, we've got the audio as well. And so it's building back and forth depending on all those. Because when that's a very broad statement. That's why I had a little trouble with it
Yeah.
first.
Yeah. And I'm looking at the clock and I see we only have a couple of minutes, and I want to ask, there are a couple of questions, and there are a lot of questions here that I'm not going to be able to get to, but a couple of questions tying back to the organizational aspect. And so I guess I'll start with the first one because it's sort of the biggest one. What is the biggest challenge that you find in creating a health literate organization?
It's creating the momentum.
Mm.
What you have to do is that I really had a great compliment paid to me. The chief nursing officer at Johns Hopkins said to me that from the day you interviewed, you have continually been focused on outcomes, on the impact of the work that you do. And to hear that from her over 8 years is such a compliment, because that's been the critical point, is to realize that health literacy is an important tool in the care of that individual. We have to remember we come from a paternalistic um, uh, healthcare has always been a bit paternalistic back in time, and now we've moved to more partnerships and shared decision making and those types of things. And so having a focus on incorporating the patient in those clinical decision making and so forth, and the possible impact of all that is critical. When people can see what it is that you're impacting and how you can help them solve the opportunities that are out there. For example, when you take a look at the opioid crisis, for example, creating the tools for patients to be able to effectively manage their pain in ways other than opioids when they need them, obviously. Those kind of things over time build credibility, show the value of our science. And so it's the elevating of that science, but doing it in a what I would call passionate, persistent, polite way is in a critical point of moving an organization in that direction. Michelle, would you add anything different there?
No, I think that was well said, Tom.
And I think that's a really nice, actually, a really good way to end this. So I will, we're right at the top of the hour. Thank you both for being here. Everyone who's here, thank you for coming. If you'd like to continue this conversation, we'll set up a discussion on the discussion list on the Health Literacy Solution Center. And be sure to be on the lookout for future webinars. In August, we're going to be doing a nursing panel to get different nursing perspectives on health literacy. And so we're pulling that together right now and are excited to share that information with you once we've got that ready to share. And I think that's it. Thank you so much for everyone. And a big thank you to Tom Bauer and Michelle Heacox. We really appreciate your expertise, and have a wonderful rest of your day, everyone. And this is recorded. You'll be seeing this on the Health Literacy Solution Center within the week. Take care.
Thank you all for joining us.
Yes, thank you.